So this brings us to specialty pharmacies. Pharmacies that are aware of these drugs, aware of these special patients, aware of the costs and benefits. They have a place in all of this?
We do believe that they do. Actually, I think earlier we mentioned about making sure that there's no, the waste is very limited in blood factors, and I think where specialty pharmacists that have that expertise comes into play also in terms of how they manage the patient's inventory, how they manage the assay also to cut down on waste, and also the wraparound services that are provided to patients, and also the coordination that the specialty pharmacist is able to facilitate with the prescriber, and also in between different specialties. I know we mentioned SLE being one of a disease state that impacts various different organs, be it also dermatology, nephrology, and what have you, and which not all the time do you have that accurate or timely exchange of information among or between specialties also.
But
so
Patrick,
part of what specialty pharmacists can do is that, coordinating the flow of that information.
well, Patrick, there's a role here, right, for collaborative, comprehensive, coordinated care. This all sounds really good in theory, right? You've got payer partnership opportunities. There are hemophilia treatment centers, home care companies. It sounds great. Why don't we all just join hands and sing Kumbaya and walk together into the sunset? Does it happen that way? Do they work?
Well, I think an interesting feature of hemophilia programs is that they are recognized as entities that can access, for instance, 340B pricing. And so many hemophilia treatment centers have their own hemophilia drug programs that allow them to pass on cost savings to the patient, and at the same time, through the proceeds of the sale of the factor, give back to the patient, and sponsor educational efforts, social work, support, physiotherapy clinics, to enhance the the care of the patient. I think patients with hemophilia should get their factor from the entity that works for them, that makes sure that they're going to get it in a timely manner and with the appropriate controls. And I think when it's done right, it can work great if there's a specialty pharmacy involved.
How are clinical strategies then for hemophilia, for lupus, balanced with your concerns? We've been sort of tap dancing around this all day long. Are there concerns where you're just going to say, no, this isn't going to work, or worse yet, perhaps, no, your plan will not pay for it, despite the fact you're going to benefit from it?
Well, the no comes in when something's just not FDA approved and it hasn't even been studied. If it's purely investigational, then usually the no is justified where the patient really should be in a clinical trial. Because that really should be, it's under investigational research, that's the entity that should pay for the cost. There's always room for appeal, and that's where the individual consideration comes in, and discussions like we just had in terms of how do you know it's going to work for this patient? What else have you thought about or has been tried to help us understand that hopefully there's this high-cost drug hopefully has some chance at working. But it gets back to, I think, the care coordination and the waste in the system. So before we limit drug, I think the broader opportunity is how do we get payers and what we call KOLs, which is thought leaders, to be able to come together and have this dynamic discussion about what are they seeing in the industry that are missed opportunities. So before we even get to drug, it may be adherence, it may be site of care, it may be where are they seeing the waste, and how can we have a better dialogue? Because there's a lot of people that may be touching the patient in terms of the outreach, but where does that information get stored? How does it come back to the treating physician? What's clinically meaningful? At what point would you want to know if a patient's having a side effect that may avert a hospitalization? And those are some of the dialogue and the discussions around best practice that I think we could all value from.